Hello, hello, hello. Welcome back, everybody, to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I am your host, and I'm a filmmaker that's been working with CCF for a decade. We started working together in 2011. I was living in New York at the time, and we started with a whole video series that year that we've now updated last year. And along the way, we've recorded all kinds of videos and now have started producing live video series, all with the same mission in mind, which is to educate people to raise awareness about neuroendocrine tumors. I feel extremely grateful to be a part of this community. I appreciate you all welcoming me and allowing me into it. And I really, really love cultivating the community that we're doing here on the show and at the foundation. And I love all you all. This is almost a year of Luncheon with the Experts that we've been doing this. I think July marks the year of our first season, hopefully of many more. But it has been an awesome, very impactful show for me, and I hope for you as well. So if you are a friend of the foundation, you probably know the drill, and you're letting us know in the comments where you are in the world. But if you're a first timer, welcome, and let us know where you're signing on from. We love to see how far these programs reach. Inevitably, every week while we're live, people are tuning in also live all over the world when it should definitely be bedtime. They're still tuning into Lunch with the Experts. So that says a lot to me about the impact of our show and that we're doing a good job. That's valuable feedback, I think. So before we get started, we always want to thank Tercera Therapeutics. We honestly couldn't do the show without them. So big thanks to our presenting sponsor. We always have this disclaimer at the top of the program that we like to say, and that is the opinions expressed by the guest, as well as the questions asked by the audience that you all at home haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So, okay, that last line is really the crux of it, really the takeaway that I want you to have. We're going to give you some answers to your questions. We're going to give you some guidance for your journey and some direction. But by no means do we know your specific case. So please take that information and those questions that we give you back to your home team who does know your specific case and make the best plan for you moving forward. So today our guest is Dr. Julie Hallet. How are you, Dr. Hallet?
Very good. Thank you very much for having me. It's very exciting to be on this Luncheon with the Experts series.
Oh, well, we're happy to have you. So for those that don't know you or aren't familiar with the work that you do, where you work, tell us a little bit about yourself and where you fit into this neuroendocrine tumor community.
Yeah, so I'm a surgical oncologist, which means I'm a cancer surgeon. I specialize in liver, pancreas, and gastrointestinal, so stomach and intestinal surgery. And within that, I also have a particular specialization in neuroendocrine tumor care. And I work in Toronto, so I'm affiliated with the University of Toronto, and the hospital I work at is Sunnybrook Health Sciences Centre. And in there, I dedicate probably about a third of my practice solely to neuroendocrine tumors. And
Okay.
I'm part of a multidisciplinary group. So we work in what is now named the Susan Leslie Clinic for neuroendocrine tumors. So we have a core group of about 5 oncologists, and I'm one of them that specialize in neuroendocrine tumors in Ontario, Canada.
Awesome. Well, I know the folks always have a lot of questions about surgery, so I'm sure that we will be jam-packed with questions today. Let's see how everybody's doing. Good morning from Two Hills, Alberta, Canada.
Oh, great.
British Columbia. Look, we got Canada in the house. Love it.
Nice.
Australia. So I told you this stretches all over the world. Awesome. And I love seeing North Carolina. What's up, David? Germany, Florian, good to see you again, my friend. Tough loss the other day in the Euros with the own goal. Oh, I love the German team. Anyway, so let's get ready to start the show. Go ahead and start sending in your questions. We're going to try to get to as many of them as we can. Inevitably, folks, we get lots and lots of questions, which is a good problem, but we can't get to them all. So if at the end of the show we didn't get to your question or you have a follow-up question, I really urge you to reach out to the Carcinoid Cancer Foundation. You can private message them here on Facebook. You don't even have to leave the app. You can go to carcinoid.org. You can reach them there directly at their website. Either way, they will get you the answer or get you the information to the person who will get you the answer to that question. Also, this video will live here. It'll be evergreen on the Facebook page under the videos tab. You can access it tomorrow, the next day, next year, as long as Facebook is still up. And starting Monday, for those who don't have Facebook, we republish these videos to YouTube, so you can access it there as well. So you can always refer back to it. There's a couple of things I like to ask you all to do, which helps me do my job better. And one of them is to let's get as many people here as possible. I mean, that's really the benefit of this show. Like I said, you can rewatch the show, or someone who wasn't here right now can watch it later and still get a lot of information. But the real value, as far as I'm concerned, is this interactive one-on-one session with a specialist, with an expert, asking a question and getting an answer to it. That's huge. So if you know someone who would benefit from this, tag them in the comments, share this video to their page. Just let them know the show's going on. We'll be here for an hour. They have plenty of time they can join, but the more people here, the better we can serve the net community. And that's our job. And secondly, my second ask, you all do a great job of this every week, so I'll continue to say it. If you see a question in the sidebar in the comment section that you also have, or you're interested in the answer to, or learning more about, just hit that like button. Love any of the reactions Facebook gives you. Any of them work the same, so like is fine. What it does though is it effectively upvotes the question. It lets me see that, hey, 6 people are interested in this question. So as I'm scrolling through, that's going to kind of let that show me there's a demand, and I'll make sure I get that across. You all have been doing a great job at that, and I appreciate it. It helps me do my job better. Finally, before we get started, have you downloaded CCF's free Net Cancer Health Storylines app? This app is really, really good. It makes it very easy for you to record your symptoms, your medications, your moods, your nutritional concerns, and more. If you haven't, check it out. We will put a link in the comment section. And to that point, if there's anything that Dr. Hallet mentions today, medication, article, any resource like that, we'll try to add that into the comments section for you as well, so you don't have to jump out of the show, open a new browser window, go to Google and search it yourself. We'll do all that hard work for you and put it in the comments section. All right, that is our housekeeping. Let's get the show started. So, Dr. Hallet, I was curious. I know you've been working, 30% or so of your patients, you said, are net patients. Do you remember your first one?
Yeah, I think I was a resident, was a first year general surgery resident, and I was lucky enough to start my first general surgery rotation on a service that had a lot of oncology patients.
Okay.
And one of my mentors over there, Dr. Jean-François Hallet in Quebec City, had a neuroendocrine tumor practice. And so I went to his outpatient clinic and saw our first neuroendocrine tumor patient. And I always knew I liked treating cancer because I find it a very challenging disease to approach surgically. But the complexity and the challenges with the management of neuroendocrine tumor patients really became clear when I attended that clinic with him, and made me intrigued about that disease. And the more I read about it, the more I learned about it, the more interested I was. And I have to say, I have to thank him for that, because his passion for this disease just, transpired through his teachings. And that's how I got interested in it. Yeah. And then a few years later, I remember a patient who I cared for as a senior resident. I think I was in 3rd or 4th year of residency. And I will always remember that patient. Was a man with a mental delay disorder. So he had been bullied for a lot of his life, came to hospital with profound weight loss, and had symptoms for years, but nobody ever paid attention to them, and arrived in hospital in extremis. And no one knew what he had. And eventually, after working him up in the emergency department, we found a small intestine tumor and liver lesion. And sure enough, he had carcinoid syndrome from a metastatic small intestine neuroendocrine tumor. And the carcinoid syndrome was so advanced that his body had started consuming itself.
Wow.
Yeah, we operated on that man because of the blockage on his intestine. And I was part of that surgery, and I followed him up afterwards. Even when I was off rotations, I was off that service, I went back to see him. He was somebody very fragile that couldn't express what he was feeling and what he needed. And other people would just, pass by. But yeah, I remember him very well.
You had mentioned what was your mentor, the doctor that got you into this disease? What was his name again?
Dr. Jean-François Ouellet. He's in Quebec City in Canada.
Yeah, this story is pretty common. I've heard with a lot of the guests that we've had on the show, of having someone that has kind of ushered them into this disease, or taught them about it, taken them under their wing. So I love to hear that. The value of a mentor is significant. At that time, what did you know of the disease with that first patient that you mentioned? Did you remember anything from medical school, or was it almost like starting at square one?
Remembered from medical school that is something that existed.
Right.
And, those questions come often when we talk about exams and general surgery and whatnot, but, those are all theoretical concerns. And I think, to me, the two things that were most interesting when I saw those patients and talking with Dr. Ouellet at the beginning is, number one, the complexity that, what's in the textbook is not all there is. Like, those patients are all so different from one another. There's not two treatment plans that are the same. And I find that very challenging and motivating to work with. Like, there's sort of a very tailored approach in this disease, more so than in any other cancers, that I really enjoyed. And then the other thing I'd say, it's the patient stories. It's, the fact that often there's been delays in diagnosis, that they've seen a lot of the doctors that didn't know what to do with this or know anything about the disease. And so hearing those stories like really motivated me to say, it's something that's challenging to treat. It's a professional challenge, but also, I would say, a human or a personal challenge, to try to help those people as much as we can, and really have an impact and make a difference, hopefully.
Got it. Love it. Well, we've got some questions coming in already, Dr. Hallet, so I'm going to go ahead and pivot to that. So our first question comes from Mary. Mary says, can Dr. Hallet speak about the journal article published 2 weeks ago on her research into cancer-specific causes of death in NET patients? Specifically, did the study account for grade in addition to site and metastatic spread? And if not, how would she consider grade to play into the discussion beyond the specific parameters of the research? And a lot of other people are interested in this question as well.
Yeah, so that's interesting. It's funny, that article was just published and got a lot of attention. I actually have to write a quick summary for NANETS after we're done with this recording. So maybe I'll practice what I'm going to write for them right now. So so this study, for those who haven't seen it, looked at cancer-specific death or cancer-specific survival after a neuroendocrine tumor diagnosis. And the reason we wanted to look at that is because, as many of you know, and with neuroendocrine tumors, there's a very prolonged survival. It's a slow-growing disease, and people will live for a long time, even with active tumor. So often we figured that, patients may die from other causes before they die of their neuroendocrine tumors. And that's important to know because, depending on how much of a threat the neuroendocrine tumor is to one's life, then we may or may not want to be more aggressive with our treatments. And with a disease that in some instances can be very indolent, I think it's important that our treatments are not more toxic than the tumor itself. And so that's why we came about with this question. And so what we found is that in some specific types of neuroendocrine tumors, actually the risk of dying from other things, so not dying from cancer, is much higher. And for that, we're talking about stomach neuroendocrine tumors, pancreas neuroendocrine tumors that are not metastatic, and some rectal neuroendocrine tumors that are not metastatic. In the other types of tumors, so everything that's metastatic, small bowel neuroendocrine tumor or colon or lung, then the risk of death from cancer is much higher than the risk of death from other causes. So I think what this shows is that there's sort of a dichotomy in that, and we know that all neuroendocrine tumors are different, right? Like the stripes of a zebra is what we often talk about in this field. But so there's some that are very indolent and do not present a very big threat for the patient's life. And we're thinking about, small gastric neuroendocrine tumor, like the type 1 gastric neuroendocrine tumor, some small non-functional pancreas neuroendocrine tumor, or some very small localized rectal neuroendocrine tumors. And in these circumstances, often we end up monitoring rather than doing big surgeries or providing toxic treatments. And I think that what that data showed us is that that's a reasonable strategy, and it's important to have that option and discuss it with patients, because their treatment might be more detrimental to their life than the tumor itself. However, there's other circumstances where the cancer, the neuroendocrine tumor, presents a big threat for one's life or one's quality of life. And that's the metastatic, the small intestine, the long neuroendocrine. And in these cases, and we should be more aggressive, we should look at all options to treat this disease. And so I think that that was sort of intuitive. If we talk to neuroendocrine tumor experts, they would probably tell you this, but we really put data on it so that we can present it to patients. Because often patients would ask me, okay, you're telling me it's not a threat, but what does this mean? And so right now we can say, well, I know that your risk of dying from something else is 3 or 4 times the risk of dying from this in the next 5 or 10 years. And I think that that just adds meat to the bone when we have those discussions. With regards to grade, unfortunately, in the data set we used, we did not have grade information. So what we did is we used administrative data sets in Ontario. And in Ontario, Canada, we're very lucky that every interaction with the healthcare system is recorded because we have public universal healthcare in Canada. And we have access to that information for research purposes through a research institute called ICES. And so that allowed us to follow every patient with neuroendocrine tumors over that time period. Wow. Until their death or until they move out of Canada, essentially. And so that gives us very rich data, but unfortunately, we didn't have the pathology details necessarily. I'm working to fix that. We have acquired about 8,000 pathology reports in Ontario, and we just have to manually abstract them into a database that will combine with the provincial data. So that's coming up in a year or two. It's in the works, but for now, we're not able to address grade. What we did, though, is we looked at metastases. So in general, the ones, we know that the gastric or the rectal that are not metastatic at diagnosis are more often low grade, whereas the ones that are the high grade might be more metastatic. So that's how we made that distinction, but we don't have, very granular data about the impact of grade.
Awesome. Thank you for that. And thanks for your question, Mary, and everyone else. Hope that helped. Next question, our friend from Germany, Florian. Florian says, my question is for a young woman. She was diagnosed recently with a carcinoid tumor in her lungs. And now she has high blood sugar, but she's had no problems with that before. Is there some sort of connection between that and the carcinoid?
I guess it depends on the treatments. One thing that can increase blood sugar is long-term treatment with somatostatin analogs, so either sandostatin LAR or octreotide, that is often used to treat neuroendocrine tumors, can make blood sugars go up. In our clinic, all those patients are followed by endocrinology or in close relationship with her family doctors to monitor blood sugars. So if she's on those treatments, then that could be a reason. Otherwise, for a long neuroendocrine, I don't really have any particular explanation for it. Like, the one thing that we all need to remember, and I see that often in clinic, is that neuroendocrine patients are allowed to have all sorts of other problems that are not related to neuroendocrine. And that's one of the things that, and I'm not saying that's what we're trying to do here, but just as in general, one thing I've been trying to do with primary care providers or, other oncologists is not label patient as carcinoid or neuroendocrine, and then sort of, focus on that every time something happens and miss other things. Right. I've had a patient who had dizziness and chest pain and all sorts of issues, and everybody thought he was having actually flushing and said it was neuroendocrine until he came into my office and was actually having a heart attack. Jeez. And his symptoms were all related to heart disease, but because he had that label of carcinoid on his chart, and people know that anything can be attributed almost to carcinoid, like we're going into that direction. So I guess it's just not specifically about this particular patient, but in general, like a word of caution that you have to exhaust all other explanations as well before we can attribute something to the neuroendocrine tumor.
Such a great point. And I don't think anyone's really put it that way before on the show. And I can see why that might be problematic. and something that needs to be addressed. So I really appreciate you saying that. And I hope that helped, Florian. I will say that this question kind of comes up every week about the blood sugar elevation. And so I don't want to speak to that because I'm not an expert, but I would just say that maybe some people will share their experience in the comment section. And what Dr. Hallet is definitely, what she said is what we've kind of landed on with the somatostatin analogs as one possible thing, treatment as being one possible thing to contribute to that. But maybe some people can share their experiences. But I know this question comes up a lot during the show. So hopefully that helped. Next question from Sarah and apparently several other people. When tumors are found in the liver and metastases in the bones, and was originally told that I was not a candidate for surgery due to the metastases, is surgery ever an option in the future for the tumors in the liver?
So I guess the answer is it depends, like a lot of things with neuroendocrine
Indeed.
tumors. The thing with neuroendocrine tumors, it's a unique disease in that in the presence of metastases to the liver or to sometimes other sites, surgery still plays an important role, whereas in other more traditional cancers, it wouldn't even be thought of. So first thing I would say is it's important for everybody, I think, even with metastases, to see a surgeon and to see a surgeon with expertise in neuroendocrine tumors. The reason is, if you were told initially that it's unresectable, I'd say that the ability to resect is in the eye of the beholder. So it depends who you see. And in neuroendocrine, we approach resections very differently with different parameters. So it's important to see somebody who does a lot of these things. With regards to bones and liver, it depends refers to the pattern. So if there's something that has a dominant liver disease, we call it, so most of the tumors are in the liver. And by removing the tumors in the liver, or the majority of the tumors in the liver, we could reach a resection of about 70% of the entire tumor volume, then yes, it might be feasible and it might be reasonable to do. If the tumors in the bones or outside of the liver are very widespread, and because of that, removing the tumors in the liver would only remove a small portion of the overall tumor burden in the body, then it's not worth it going through liver surgery for that. The other thing that's important to consider in that is also the functional aspect. So we'll be more aggressive going for liver surgery if somebody has hormonal symptoms, because the tumors are making a lot of hormones, and by removing a part of them, we can help with the symptoms related to those hormones. So there's a lot to consider here. I guess that's a long and winded answer to say it depends. And the important thing is to see a neuroendocrine surgeon. So somebody who does a lot of those cases, and to seek out those people. And maybe the answer is that it's more reasonable not to do it, but at least then you'll know that you got that answer from someone who's used to approaching these tumors with a particular eye for liver resection.
Got it. Thank you. You know, instead of long-winded, I like to say thorough, and I think that the attendees of our show appreciate that.
Awesome.
Folks, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. If you're just joining us or joined us late, welcome. We are here today with Dr. Julie Hallet, a surgical oncologist, and we're getting a lot of answers to our questions already. So we're going to keep moving along. Joe says, I had my first octreotide shot, a lung node with liver metastases, non-functioning. Can you speak about the resulting bloating and diarrhea?
Yeah, so I'm not a medical oncologist, but I do treat a lot of patients with somatostatin analogs like lenalidomide or octreotide, LAR. Actually, we have so many patients in our practice that are medical oncologists and not able to follow all those patients. So when they are only on SSA, the surgeons will take care of that. What I would say is, yes, it can happen. It's part of the side effects, but usually it's very short-lived and would typically happen immediately after the injection. So there are some patients who will have like 2 or 3 days immediately after the injection of bloating, some diarrhea, and then it goes away. With the diarrhea, if the tumor were functional, then I'd also recommend to check whether the hormonal aspect of the tumor is controlled and that diarrhea is not related to carcinoid, for example. But that's something that can happen over time. From what I hear from patients, it tends to get better. And usually it would be self-limited the first few days in that cycle, the monthly cycle for the injection.
Got it. Karen says, do any of your patients get a rash on top of the injection site and surrounding area?
I don't really think that that happens commonly.
Okay.
It's certainly been reported. I wouldn't feel that it's dangerous, but I would talk with your oncologist about it in more details.
Amber, next question. This is back in regards to your article that we mentioned earlier. What about nets located in the appendix? What is your opinion on these pertaining to the article?
Yeah, so again, I feel like I'm going to say this a lot in the next, maybe we still have half an hour. It depends. So there's neuroendocrine tumor in the appendix, the vast majority that are not dangerous and probably would have never caused any trouble if it weren't for another very common problem called appendicitis. So most nets in the appendix will be found because somebody had their appendix out for appendicitis, which happens in about 10% of the population. So it's, a common problem.
Right.
And when we find it that way, often they are small and I would say inconsequential in most cases. If they are larger, then they can create more problems. So when we see nets in the appendix, if they're very small, so measures, less than 1 centimeter, and there's no other features, like there's no tumor around the appendix, no involvement of lymph nodes, then often those won't have any impact on one's life. To be very, very safe, we do follow those patients for about 10 years with imaging to make sure it doesn't come back. But I think it's like out of an abundance of caution in most cases, like I would have to think about the patient where we detected a recurrence actually in that setting. If the tumors are much larger, so over 2 centimeter, or their lymph nodes that are associated with it, then generally what we'll do is we'll do a bigger surgery. So we'll go back and we'll take out the right side of the large intestine to which the appendix is attached. And that is to get some of the lymph nodes in that area and make sure that the treatment with surgery was complete. And then if you've noticed, I said below 1 centimeter and over 2 centimeter. I didn't say anything about the in-between. And that's because the in-between is very debated right now in surgery. Our traditional teachings would tell us that if there were high-risk features between 1 to 2 centimeter size, we would have to go back and complete the surgery by taking the right side of the large intestine. But nowadays, what we've realized with a number of other studies is that by doing so, we're actually not changing people's survival. Like patients are not living longer because we take more intestine out. Though what happens is that they can live with the consequences of intestine coming out, diarrhea, leakage from the connection during surgery, and all sorts of things that can really alter quality of life. And so more and more, when it's below 2 centimeter, we're trying to not operate and just once the appendix is out, just monitor things. So again, a thorough answer, I guess I'll call it now, to say that most often when they are very small, caught because you had the appendix out for appendicitis, that can just be monitored for a few years to make sure it doesn't come back, but is unlikely to change your life in any meaningful way.
Got it. Thank you. Going back to the blood sugar potentially being affected by somatostatin analogs, Mary said, will a somatostatin analog affect blood sugar if you've had a total pancreatectomy?
So that would be then a very different situation, because with a total pancreatectomy, you're diabetic. It's been what we can call brittle diabetes, which means that you just don't have a pancreas. There's absolutely no endogen insulin. The body is producing no insulin at all. So you're completely dependent on insulin injections. So their blood sugars would be more due to the absence of a pancreas than the somatostatin analogs. And anybody with a total pancreatectomy needs to be carefully monitored with an endocrinologist for diabetes, but also for the other thing that the pancreas does is produce enzymes for digestion. So you need to have pancreatic enzyme supplementation for what we call exocrine insufficiency. And that's where the endocrinology follow-up is really critical.
Got it. Thanks, Mary. Terry says, when watching growth rates of recurring lung nets, we're getting a lot of lung net questions. I hope that's okay today. What is considered slow growing versus fast? For example, 1 centimeter and 5 years ago, and now 1.7 centimeters. Original tumor, typical net with mets to pleura.
So there is no like one specific cutoff or one specific size. Like I don't have particular numbers. When we do clinical trials or studies, we use things like the RECIST criteria, but that's those are sort of arbitrary measures that were decided upon a number of years ago so that we all measure the same thing when we do clinical trials. In reality, what's important is not so much a number than the pace. So it's about a trend over time. So we need to have like multiple imaging studies and look at what the trend is. So, you know, if it grows by 2 millimeter, and then the next time that has doubled or tripled, that might be more significant than if it grows by 5 millimeter and then does nothing after. So it's really about the trend and continued and ongoing surveillance, which speaks again to the importance to have continuity of care with these diseases, so that aspect can be appreciated. I'm sorry if that's not a direct answer, because I don't really have a specific number for you.
No, that makes sense. Thanks for your question, Terry. Next, Basima. My mom was diagnosed with carcinoid in her intestines with neuroendocrine metastasis, and she's been on Sandostatin for 13 years now, but now she's having terrible pain in her bones, knees, and ankles. We've also heard a lot recently about joint pain on the show. Is Sandostatin enough? Should there be something else that she's considering?
So at this point, I think it depends of where what the symptoms are from. If the bone pain is related just to the somatostatin analogs, then you can discuss other management strategies or taking a break from somatostatin analogs and see what the disease does. If the joint pain or the bone pain is related to tumor in the bones, then, you know, there's options for supportive care. So, you know, pain management specifically to the lesions, or, you know, treating the entire disease more aggressively. So I guess it depends of where the symptoms are coming from. In general, you know, changes in management or adding additional therapies will be related to either tumor progressing, and by tumor progressing, I mean growth of the actual tumor volume that we can measure on imaging, or hormonal activity, because sometimes the tumors don't grow on the images, but they're hormonally more active, and that could be considered progression, a reason to add on treatments. And then the symptoms are also important, symptoms related to tumor, in addressing additional therapy for management. Now, and the SSAs are really, you know, the backbone of therapy. I tell most of my patients, you're going to be on this for years to come. That's the ideal scenario, that we don't need to do anything else for years. And then even when we want to add something, that's really what we're going to do. We're likely going to add something to the SSAs rather than taking them off and replacing them by something else. Sometimes we do that too, but in general, we just add therapies to get even better control. And that is when there's progression.
Got it. Thank you so much. Folks, we are just a little over halfway done with today's episode, where we've answering a lot of great questions. Sarah says, thanks for answering my question, Dr. Hallet. I appreciate it. Just a reminder that if we don't get to your question, follow up with Carcinoid Cancer Foundation. They will get you the information you need. You can message them privately here or go to carcinoid.org. And then we will keep the video here on Facebook, so you can always refer back to it. Starting Monday, we will put it on YouTube. The numbers are looking great, so you all are doing a great job of getting people here. One of the things I love about the show is we have Dr. Aman Chauhan in the audience, a friend of the foundation. Says, hi, Dr. Hallet, great to see experts from the other side of the border. Hola, Rain, ¿cómo estás, mi amigo? This is the community that we cultivate. We have the experts come back and watch the show and contribute.
Yeah, and that's wonderful. You know, I said one of my mentors got me interested in neuroendocrine tumors, but also the thing that keeps me going and makes me so interested in this work is the neuroendocrine community, and you know, other physicians, healthcare providers, and patients. It's a very, very engaged community, and I have to say that finding those other providers like Dr. Chauhan and a lot of others, be it in person when we go to meetings, or, you know, in the past year and a half on social media or things like that, is really, you know, the cherry on top, all this work, and what makes it even more exciting.
Absolutely. I have to agree. I mean, for me, I'm not a medical expert. I'm not a doctor. I've learned a lot working with CCF, but I'm really, you know, I'm a storyteller. I'm about the heart of it. So I love the community that is cultivated here. I have to agree. And I've worked with other diseases. and maybe I'm biased because of my work with NET patients, but the community is so strong, and I see it here in the show. And that for me, I think that's one of my most favorite things to see, is just how strong that community is, and that includes the community members like the experts, like yourself, the doctors, as well as the patients, as well as the caregivers and support group leaders. It really is all of them. Which kind of that leads me to a question you had touched on in the very beginning. You were talking about the multidisciplinary center where you work. And I mean, this is another way to look at it. It's a multidisciplinary community, right? All those people are very important to the quality of life that patients, have with this disease, and for all of us learning more about it. But with your multidisciplinary team, what is that made up of? Who is important? Why is that important? Why is that what seems like the most effective way to approach this disease?
So I have to preface all this by saying that right now we're not functioning like we normally do because of virtual care.
Yes.
So I'm going to tell you about what's your usual setup that hopefully
Right.
we'll get back to very quickly. So the multidisciplinary clinic was actually funded by Dr. Simran Singh and Dr. Calvin Law. Simran Singh is a medical oncologist with our team, and Dr. Calvin Law is a surgical oncologist. So he's my senior colleague who hired me as part of this team. And they put this together, only the two of them. And what they had realized, that's the story I've been told, is that patients would, go to a medical oncologist and go to the surgeon and go back to a medical oncologist and go to the interventional radiologist doctor, then eventually maybe go to a radiation oncologist or nuclear medicine. And we're sort of bouncing around like that for a while. And that could be, after you've had a long-winded path to getting a diagnosis and finding experts, can be very confusing and distressing. So what they decided to do is create this clinic where patients could see the both of them together and get a multidisciplinary treatment plan established immediately. So as opposed to what we often do in cancer care, which is we see the patients and then we get at those weekly tumor boards and review things and make up plans and then relay them to patients individually, they were doing all of that at the same time. And the clinic sort of, grew over time because as they say, build it and people will come. So they were sort of victim of their success, I guess, and then had more people join. So right now, so Dr. Singh is a medical oncologist. He has a practice exclusively dedicated to neuroendocrine tumors. We have two radiation oncologists, Dr. Sten Meyerhog and Dr. Sylvia Eng, and they really pioneered a lot of radiation techniques for neuroendocrine tumors, which is a field that typically people thought radiation wouldn't work for. And now they also are the ones who deliver the PRT treatments in our group because of the radiation expertise. And there's two cancer surgeons, so myself and Dr. Law, and we're sort of the core oncologists. And so in normal times, every new patient will be booked to our multidisciplinary clinic. We have that every other week. And one of us will go do the assessment, and then we'll all review the information together, and we'll go back in the room with the patient all together to present a multidisciplinary plan. So some patients may not need me, some patients may not need Dr. Singh or Dr.
Right.
Meyerhog, but at least they know that we exist. We're there to participate in the discussions as their care moves forwards over the next few years. And then we have sort of a network of people who also specialize in neuroendocrine tumors, though are not always in the clinic with us. So we have a psychiatrist who specializes in psycho-oncology and has a unique interest in neuroendocrine tumor, Dr. Eli Eisenberg-Gresta, who's seen a lot of our patients. And he likes to study and understand better the unique interface between the hormonal repercussions of neuroendocrine tumor and psyche and cognition. So he's been very helpful for a lot of our patient population. We have a team of social workers, nurses, drug reimbursement specialists that also work to support patients and have a lot of experience with neuroendocrine. And then finally, we have an endocrinologist, Dr. Angela Assal, who is one of the few endocrinologists who work within a cancer center and has a cancer clinic to see all of our patients. And, she wasn't with us at the beginning, and I thought that we were doing a pretty good job managing hormonal syndromes. And, you don't know what you don't know. And now that she's with us, I realize all the things that we didn't do before and how much of a difference she really makes. And then we have a pharmacist, Alia Thauer, who works with patients on oncologic therapy and will proactively call patients to monitor side effects and manage those with them, etc. So it's a really big team.
Yeah.
Yeah, and what we're trying to do, we see about 1,000 patients with neuroendocrine tumors every year, which is the largest neuroendocrine clinic in Canada. And we cannot see everybody all the time. We cannot possibly, follow up everybody. So we've established a number of partnerships with other oncologists in the community. So what is called shared care models. So we can also enact proximity care for patients. So if people have an oncologist closer to home, then we'll work with that oncologist. So we might see the patients one time with our entire team and then create a plan that we relate to the oncologist over there. And then we work together for those plans to be enacted locally. And that's a way that we've tried to, spread out the expertise across the province.
It really is a big team. That is awesome. All right, let's move back to some questions from Rebecca. Says, thanks for your time. So I've been told that low grade with metastases, the life expectancy is roughly 5 years. From your, I know this, this could go a lot of different ways, but from your research, what does it show in terms of that? Would you agree with something like that? Or where can Rebecca find out more information if she wanted to find it in terms of that?
I think to be able to really understand prognosis, the few things you need to know is your exact grade. So, not only low grade, but is it grade 1, 2, or it's probably grade 1 or 2 if it's low grade. What's the exact KI 67? Because, grade 2s are everything over 2 to 3%, depending what you read. But, 3%, 5%, or 20% are very different low grade tumors. So that's important to know. And then what is the extent of the metastases? Are we talking about, 2 lesions in the liver? Or are we talking about widespread tumors to the bone, lung, liver, and lymph nodes, for example? So all that would alter the prognosis. I would say in general, what I tell my patients is our prognosis is measured in years and multiple years. And in Ontario, our data suggests that in all people with neuroendocrine tumor, the 20-year, so that's 20-year survival is close to 40%. So that's excellent, knowing that 50% of patients with neuroendocrine tumors will have metastases or live with active disease. And all that to say that estimate is highly dependent on the specifics of a low-grade metastatic tumor. And often it might be more than 5 years, but it depends on those specifics.
Awesome. Thank you for that. And thank you for your question. Next question from Michi. My husband's tumor was identified a year ago, metastasized to his bone and located in the area of his mediastinum. Is that right? Mediastinum?
Yeah, mediastinum. Yeah.
Mediastinum.
Got it.
The location renders it inoperable, and he is on afinitor and lanreotide. His weight is a challenge. We are continually told his tumor is rare. Knowing that you're a surgeon, have you ever worked with a patient with a similarly located tumor?
So what I understand is this is originating from the mediastinum. So often those neuroendocrine tumors can be thymic neuroendocrine tumors. And those are very, very challenging to treat. So they're not the typical neuroendocrine that we talk about, where we treat with somatostatin analogs and debulking surgeries and that type of thing. So that's more, we have a number of those patients in our practice as a group, and they're very challenging, and they're mostly treated by Dr. Singh because they require a bit more cytotoxic therapies in general. That's what I can say about this.
Got it. So it sounds like their doctor is accurate that tumor is very rare, Thanks, Michi. Hope I'm pronounced that accurately. Karen says, does BCAA amino acids, is it leucine? Composed of leucine? Isoleucine?
Ooh.
Valine? Oh my gosh, you're killing me, Karen. I'm gonna skip that one. No, it's spelled Leucine.
Yeah, to be quite honest, I wouldn't know how to answer that question. So
Okay.
I'm going to have to pass.
All right, cool. Well, we'll put it off on you, not on my mispronunciation. And we'll just say that question is not right for our guest today. Sorry, folks. I learn every week too. Dorothy says, I get a CT scan every 6 months. I also see my oncologist and my surgical oncologist after each scan. Is it really necessary to see both every 6 months?
I think that's something to discuss with them. In our practice, we'll like assign one person who's the like primary person responsible for follow-up, so as to avoid having multiple appointments where you sort of hear the same thing. But we also have the ability that, if the medical oncologist, Dr. Singh, sees that there's progression, and he's going to bring it back to our entire group and get the surgeon's opinion. If that mechanism is not easy, then it might be good to see both, so that if there's a surgical option for progression that maybe the medical oncologist wouldn't think of, then the surgeon can catch on it, and vice versa. So it really depends how the team is structured and how they work together.
Got it. This isn't really a question for you, Dr. Hallet, but really quickly, I just want to bring attention to it. Mary says, could this series consider a discussion with a psychiatrist, as Dr. Hallet described? I think learning about the relationship between hormonal disruption in NETs and psychosocial behavior would be very helpful. Mary, I think that's a very valid point. And we'll talk about that for sure, because we here, at the show and at the foundation completely agree in the multidisciplinary approach. We are focused on the mental, emotional, psychological, and physical approach to this disease. So really good point, Mary. I appreciate you mentioning that. We got just a little more than 10 minutes left. Let's keep moving along with questions. John says, I hadn't thought that about it being able that it can metastasize to bones. So I have 6 monthly scans following surgery for metastasis to the liver. Will an MRI or a CAT scan pick them up in the bone?
Not necessarily. It won't pick them up better than a CT scan. So I think having CT scan regularly is really reasonable. That's actually what would be recommended. There's one expert consensus about surveillance for neuroendocrine tumors. It's a combined effort from the Commonwealth Neuroendocrine Tumor Society and the North American Neuroendocrine Tumor Society that was published a few years ago. And the recommendation is mostly for CT scan, and MRIs would be in particular circumstances, but I don't think it's necessary routinely.
Got it. I just got a little forgiveness from Karen, who says, sorry, Rain, don't feel bad. I can't pronounce them either. You do a great job. Thank you, Karen. And she had sent a link or to a site which addressed what she was talking about. But unfortunately, Karen, I can't really send that to Dr. Hallet and have her take the time to like read that and answer that. So if there's any other way that you can think to formulate that question to send it back to us, we got 10 minutes. We'd love to try to get it to you. Although I know you're here every week. So try to get it across to you. We always want to help you. Dr. Hallet, back when we first started the show, you talked about the challenges of surgery, in general, especially for cancer, but even specifically with a neuroendocrine tumor. Can you tell us, talk about some of those challenges that you face as a surgeon with this disease specifically?
I can think of two things in particular. The first one is, trying to explain what the goals of the surgery are. Because typically when you hear cancer and you hear surgery, people think you're going to remove everything. We're going to cure the cancer, right? And that's not the case with neuroendocrine tumors. Often we cannot cure. If a tumor is relocalized, it's small, it's only in one spot in the small intestine or the pancreas, yes, we can aim for that. But in general, once there are metastases or it's more advanced, it's rare that we can cure. The goal is more to, control the burden of tumor, control the burden of hormones, and then prevent complications from tumors sitting there. And it took me quite a few years to be able to present it that way to patients, so that they really understand we're not doing the surgery to get rid of cancer. They're going to live likely with the cancer for a very, very long time, but we're going to control it to make things better for them. And that's something that's hard to explain, because it takes a lot to go through surgery, and you hope that you just get rid of the disease by doing so. So that's the first challenge. The second one is about, I think, techniques. The way we operate under endocrine tumors is very different. We try to spare function rather than do very large resections to get, a clear margin around the tumor, because we know that we're not removing all the tumor. We can cut close to tumors and try to save organs. So we try to save length of small intestine, try to save pieces of pancreas or veins and arteries around the pancreas, try to save the amount of like normal liver parenchyma that we have to take out with the tumors. And the reason is that patients with neuroendocrine tumors, like I tell most of my patients, they're not sprinting against cancer, they're running a marathon against cancer. And by treating now, I don't want to create toxicities or problems that in the future will make other therapies unavailable to them. So for instance, by maintaining a lot of liver normal parenchyma and sparing it, I'm allowing them the option to have more access to liver embolization in the future, or to even like a redo liver surgery if indicated. So we have to have that in mind. And if you don't treat a lot of neuroendocrine tumors and you approach those tumors like we approach other cancers, it's very easy to miss that. And I find that that's we have a lot of work to do in the surgical community to get this information across to a more broad audience of surgeons.
Got it. Thank you. Just had a question come in from Suze, who was recently diagnosed, looks like just on Friday. Sorry to hear that, Suze. I was diagnosed with a PNET 2.0 centimeters at the head of the pancreas. This is a broad question, but our question is, what do you suggest? And so is there any information we can give her about that specific location that may be helpful for her journey forward?
So yeah, I'm sorry to hear that you were just diagnosed. I hope things go well for you moving forward. I'd say in general, any pancreas neuroendocrine tumors more than 2 centimeter, if there are no metastases, I would recommend resection. The head of the pancreas is one of the toughest places to do a surgery or resection on. The surgery you need is called the Whipple procedure. I know one of your prior experts, Dr. Mark Lewis, probably talked about this quite a bit when he was there, because he went through that procedure himself and actually tweeted it. He's very famous for that now. So I guess you can find some information there, but it's a big operation. It's a life-changing operation. If there are metastases and the treatment may not involve surgery, might be based more on medical therapy. It depends on the exact pattern. And then finally, the thing that we'll need to figure out for your disease, also whether the pancreas neuroendocrine tumor is making any hormones. So is it functional or non-functional? It's only 10% that are functional, but when they are, it's sometimes like a bit of a different approach to the treatment. So I know those are like just, broad strokes of what would be happening, but I hope it gives you a bit of a direction. And there is a lot of very good websites with information on this. The Carcinoid Cancer Foundation is one of them, lots of great resources. And then there's also patient information that you can look up. So Mark Lewis Twitter is one thing. There's a patient, his name is Ronnie Allen. He's also on Twitter. He has a blog where he has, I think, some of the better layperson explanations for neuroendocrine tumors, a very deep understanding. So you can find other information there.
Yeah, absolutely. I mean, folks, I have to plus one that and echo what Dr. Hallet is saying. This, CCF, the Carcinoid Cancer Foundation, has a lot of resources on their site. This is what they do, and part of this is their job, and part of my job in working with the foundation is to create video content that helps educate people about this. So to that point, this is to Suze and to anybody else that's listening. I had mentioned at the top of the program that I've been creating videos for CCF for a decade now. A treatment-based series that we did last year, and the final episode, I think we did 9 of them. The final one was released in January or February of this year of 2021. That was on surgery, specifically featuring Dr. Mark Lewis, whom Dr. Hallet just mentioned. And he talked about the Whipple procedure. He had a diagram of the pancreas and literally showed visually, what that surgery was, which I know is a very complex surgery. So that video in this specific question or instance could be very beneficial. And, in a broader approach, we have a lot of video content that you all can watch. I mean, that talks about various elements, treatments, approaches to this disease, whether it's, PRRT specifically, or lung nets, or carcinoid syndrome. We dive into a lot of these topics, these important topics that come up with neuroendocrine patients. So just another aside that we have a lot of information there on the website and out there on the internet for you to find. So seek that out. Dr. Hallet, let's take, so Sue's example is a new patient and a very specific, type of neuroendocrine tumor. Let's zoom out a little bit there, and I want to ask what you would say to, in general, to a newly diagnosed neuroendocrine tumor patient in terms of, I know you're going to look at it from the surgical perspective, but also you're in touch with more than just that angle, it seems, when it comes to this disease. What would your advice be? If I just got diagnosed, it's day one.
Yeah. So typically what I tell patients is that neuroendocrine tumor is a unusual type of tumors. I don't want to use the word rare anymore because it's now one of the most prevalent tumors, even more prevalent than pancreas, gastric, or esophageal cancer. So I try to use the word unusual or uncommon. So I tell people it's an unusual type of cancer, and that it is unique in two ways. Number one, it's very slow growing, typically compared to traditional cancers that you might hear about in the news or the media. And second, it has the ability to produce hormones or chemicals that can add to feeling sick. And so we need to address these two things when we treat the tumor. And that in general, there will not be a single answer to how to treat this tumor, but we will have multiple approaches or multiple modalities that will often combine. And how we pick those modalities and when we use them will depend on exactly the type of tumor we're dealing with. So to get that information, we need to do, I like to separate this in like what I call structural staging and hormone staging. So the structural staging is like the organs, or like where is the tumor? So what organ is it originating from? Like small bowel, pancreas, lung, appendix are all treated differently. So that's the first thing. Where did it go? Nowhere. Maybe there's no metastases, or are there metastases? Where are they located? How many? What is the volume of them? And then exactly what are the specifics of the tumor? So we need to have a biopsy. We need to have this analyzed by a pathologist, know what is the exact grade to appreciate how aggressive the tumor is. And then the endocrine component of the staging is, are there hormones being secreted by the tumor? If so, to what extent? And how much repercussion does that have on the patient's life and symptoms? And then there's a few things that we need to look at for specific syndromes. So for example, patients with carcinoid syndromes need to do heart testing to make sure the hormones haven't damaged the heart. And there's a few other things to look at there. So the initial part is often just to have a very broad understanding of exactly what's going on, like define what stripe of the zebra you're a part of. And then based on that, we can together define a treatment plan that will often involve more than one treatment modality.
Awesome. Thank you so much for all your thorough answers today. Appreciate your time, Dr. Hallet. Thank you so much for being here. There's a lot of comments that are coming in that we'll send you in an email just talking about how great of a show this was today. And I appreciate you making it one.
Thank you so much for the invite. Always a pleasure to talk about neuroendocrine tumor. That's what I tell most people. I'm always happy to talk about neuroendocrine tumor to anybody who's willing to listen. So this is just a true pleasure for me.
Absolutely. And folks, the engine behind the Foundation Grace Goldstein has put in the comment section the video that we did that I referenced with Dr. Mark Lewis about surgery. So if you want to check that out, you can. That's our show for today, folks. Listen, yesterday was my birthday, and you all have been very sweet. I see a lot of sweet comments to me today, which is kind because I am not the expert. I am just the host. If you wanted to give me a birthday present, I would say that one place that would be a great place to do that would be a small donation to CCF. Listen, they do not know that I'm saying this, so this is not a solicitation, but CCF is a nonprofit foundation which is doing great work in the world, and so they run a lot off of donations. If you find it in your heart, if you want to give some, that would be where I would suggest. Otherwise, you can send me flowers. I appreciate being here every week with you all. Thank you for letting me be a part of your community. I want to reiterate that you can always message CCF if you have any follow-up questions. And just know that this video will be republished right here. You can always view it again next week, the next month, next year, and starting Monday, it'll be on YouTube. Thanks as always to our presenting sponsor, Tercera Therapeutics. We could not do this show without them. And finally, my name is Rain Bennett. I am your host. Thank you for watching, and please join us next time for Lunch with the Experts. Stay healthy, stay safe, everybody. Bye-bye.